Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're diving deep into a health challenge that, well, it touches millions globally, often kind of operating just beneath the surface of our awareness. Imagine this scenario. A 48-year-old man, he visits his doctor. He's got this set of classic symptoms: drinking a lot, urinating frequently, always feeling hungry. These aren't just minor annoyances, right? They're the telltale signs pointing towards a pretty significant underlying health issue. Okay, let's unpack this. This deep dive, it's built from a whole collection of detailed medical sources, all focusing on diabetes and obesity. Our mission: to pull out the most important insights, maybe some surprising facts, and definitely the actionable knowledge from these texts. We're going to use this specific case, this gentleman, to explore a much broader, globally significant health issue, really reveal its hidden complexities and critical implications.
Yeah, what's really striking here is how just a few individual symptoms, things that seem quite isolated, can actually open up this huge landscape of public health challenges. And you see how profoundly interconnected these conditions truly are. It really demands a deeper look.
Absolutely. So for our hypothetical patient, those symptoms, he's got polyuria, that's the frequent urination, polydipsia, the constant thirst, and polyphagia, excessive hunger. These are the classic indicators, the three polys they call them.
Right.
Highly suggestive of diabetes mellitus. They immediately signal chronic high blood sugar. But what does this actually mean for him? And, for so many others who might be experiencing similar things, it's not just about how it shows up in one person. It's about this whole intricate web of risk factors that lead to conditions like type 2 diabetes mellitus. For instance, age is a big one. This condition, it typically pops up after 30, and the prevalence just shoots up with age.
Yeah.
And interestingly, our sources pointed out something nuanced for India, where a lot of this research comes from. Historically, type 2 DM seem more common in men.
Right, I saw that.
But more recent data suggests there's actually no significant sex difference overall in the country now. So things change, the landscape evolves.
And if you connect that to the bigger picture, you really start to get how deeply our daily habits, our environment, how ingrained they are in shaping our health. And beyond the environment, genetics obviously plays a huge role. Twin studies, for example, they really underscore that strong inherited tendency if there's a family history. Then you layer in the lifestyle stuff. Central obesity specifically, like you said, a waist circumference over 107 centimeters for men, that's a major red flag. And the risk just goes up with how long you've been obese and, how obese you are. It really makes you ask, how do we even start to tackle something with so many facets?
That's such a key point about daily habits. And it's not just what you eat, but how you move. Or maybe how you don't move.
Exactly.
A habitually sedentary lifestyle. That's a massive environmental risk factor. And the diet part is pretty stark, too. Diets high in saturated fats, refined carbs, not enough fiber. They're clearly linked to higher risk.
Yeah.
It really suggests this fundamental mismatch between our modern lives and what our bodies actually need,
And digging deeper, you find these less obvious influences too. Things like chronic stress, physical or mental, that can actually unmask latent diabetes in people who are already susceptible.
Right.
And what's also just fascinating is this huge shift in socioeconomic factors. Diabetes, it used to be seen as, a disease of affluence.
The rich man's disease.
Exactly. But now it's strikingly common in lower social classes. And that change is deeply tied to rapid urbanization and all the lifestyle shifts that come with it. Oh, and we can't forget the risk for children if their mother had diabetes during pregnancy. That points to these intergenerational health impacts.
Which brings us neatly to the sheer scale of this problem. Because individual cases, they quickly snowball into a global health crisis, don't they?
We really do.
Our sources show over 220 million people worldwide have diabetes. Estimates from 2014 were already hitting 422 million cases.
Huge numbers.
And here's a really crucial point. Over 90% of those cases are type 2 diabetes. It's not just a health issue. It's like a demographic tidal wave.
And the human cost is just staggering. Around 1.5 million deaths directly from high blood sugar consequences in 2019 alone.
Wow.
And over 80% of those deaths, tragically, were in low and middle income countries. We often call diabetes an iceberg disease, right? Because so many cases are undiagnosed or untreated, just hidden. Back in 2001, it accounted for nearly 20 million disability-adjusted life years, dailies. That's a measure of healthy life lost. It's enormous.
And here's where it gets really interesting, especially looking at India. It's home to 77 million diabetics, second only to China globally.
Incredible numbers.
The prevalence was about 11.8% in 2019. And there's this really stark urban-rural divide. Prevalence is roughly twice as high in urban areas compared to rural ones.
Yeah, that's a consistent finding.
That's not just a statistic, right? It tells us something profound about how modernization and city living impact health. And even more starkly, India faces the highest loss in potentially productive years of life for people aged 35 to 64 because of cardiovascular disease deaths. And diabetes is a major risk factor for that. So looking at these numbers, how do we even begin to measure and then prevent something so widespread and often hidden?
Well, to really get a handle on it, especially that tight link between diabetes and obesity, we need good measurement tools. Body mass index, BMI weight in kilogram over height in meter squared, that's widely accepted as the most useful population level measure. It gives us a broad picture.
Right, the standard tool.
Consistent across sexes, adult ages.
But here's where one of the really profound insights from our sources comes in, a distinction that often gets missed. While for, let's say, general populations, a BMI over 25 is overweight, over 30 is obese. For Asian or Indian populations, the cutoffs are significantly lower. Over 23 is considered overweight and over 25 is obese.
Exactly, and that's critical.
It completely redefines risk for millions, doesn't it?
Yeah.
Someone considered normal weight by global standards could already be at high risk in India.
Precisely. It's down to differences in how fat is distributed, body composition.
That really highlights why how we measure is just as important as the measurement itself.
Absolutely. And beyond BMI, there are other methods, though maybe less universally useful. Skin fold thickness using calipers.
Yeah.
It can indicate obesity, sure, but it struggles with repeatability. It's hard to get consistent readings.
Okay.
What's really vital, though, especially for someone like our patient, is the waist-to-hip ratio. That assesses central obesity, the dangerous abdominal fat.
Yeah.
And that measure is highly correlated with things like hypertension. It gives a much better indicator of metabolic risk than just overall weight.
Right, the apple versus pear shape idea.
Sort of, yeah. And there are other indices, too, like the ponderal index or corpulence index. They all add to the picture.
So it's clearly not just about the number on the bathroom scale.
Not at all. Assessing obesity, and by extension diabetes risk, it's multifactorial. You need a proper clinical exam, those anthropometric measurements we talked about, detailed diet surveys, blood tests for cholesterol, blood sugar,
Biochemistry, yep.
and even looking at broader things like socioeconomic status, cultural factors around food. It's a truly holistic view.
Which brings us back to that crucial question.
Yeah.
Why is it so vital to understand exactly where the fat is, not just how much there is overall?
Right.
It's because that abdominal fat, it's more metabolically active. It poses significantly higher risks for diabetes, heart disease, all those related conditions. So this comprehensive, nuanced assessment, it helps us define the problem for an individual, like our 48-year-old patient. But it also helps us formulate effective public health policies and targeted healthcare programs. It's the difference between a generic guideline and a truly impactful intervention. Okay, so we understand the scale, the complexity, how to measure it. What do we actually do about it? Our sources lay out these multi-level strategies for control and prevention. For diabetes, primary prevention is key, stopping it before it starts.
Right, the ideal scenario.
And that has two main parts. The population strategy is for everyone. Maintain a normal body weight, that BMI between 18.5 and 24.9. Get more physical activity, enough protein and fiber. Avoid sugary foods, too much alcohol, stress, smoking. Basically, create a healthier environment for everyone.
And then there's the high-risk strategy that zeroes in on people we know are more vulnerable, family history, obesity, women who've had large babies.
Okay.
For them, it's about intensive education, really trying to eliminate those specific risk factors. Then moving on, you have secondary prevention.
Right.
That's about halting the disease's progress if it's already there, preventing complications.
So catching it early.
Exactly. Screening high-risk groups, blood glucose tests, HbA1c, getting adequate treatment, started diet changes, maybe drugs or insulin, and regular monitoring, blood sugar, blood pressure, vision checks, looking after the feet. For our patient, if he got a diagnosis, this stage would be absolutely critical.
And finally, there's tertiary prevention. That's about reducing disability when the disease is already established, helping people live better with it.
Right. Managing complications.
That often means specialized clinics, rehab for serious issues like blindness, kidney failure, gangrene, even patient registries to track how things are going. And India's national program, the NPCDCS, it tries to integrate a lot of this.
Yeah, it's quite comprehensive on paper.
Massive health education campaigns, screening for people over 30 and pregnant women, referral systems.
Yeah.
They even link up TB and diabetes activities, recognizing those connections.
And the strategies for obesity control, they run very parallel to diabetes prevention naturally, given how linked they are.
Makes sense.
Focus on maintaining a healthy BMI, preventing big weight gains. Often the goal is less than 5 kilograms gain in adulthood. Dietary changes are huge. Cut back on energy-dense foods, boost the fiber, more physical activity, of course, and behavioral modification, making sustainable changes. Plus, trying to prevent it in childhood is crucial because it's much harder to treat once it's established in adults. Other things like appetite suppressants or surgery exist, but they're generally used cautiously for specific situations.
Oh, okay. So, after exploring all of this, the individual symptoms, the global numbers, the tricky bits of measurement, these multi-level prevention strategies, what does it all mean for you, the listener, and for the broader healthy communities, including folks like our 48-year-old patient?
Well, I think it fundamentally means that while these big national and global programs are essential, the day-to-day management, the real success, often circles back to the individual and their immediate support system.
Right.
Our sources really stress that the patient has to take major responsibility for their own care, obviously with medical guidance. That means sticking to the diet, taking the medication, doing self-monitoring, going for those checkups.
And this is exactly where the family comes in, isn't it? Providing that critical support.
Absolutely crucial.
For someone like our patient, family members can actively reinforce those healthy changes. Diet, activity, make it a household thing.
Yeah, make it normal.
They can help with remembering medications, checking blood sugar or blood pressure, getting to appointments, even just noticing if something seems like a potential complication.
And helping manage stress, which, as we said, can be a factor.
Definitely. It really underscores that health for all idea. Health starts with the individual, but you can't protect it without the active involvement of the whole community, especially families, in planning and doing health services.
It really is a shared responsibility, from what's on your plate to national policy.
So we've seen diabetes and obesity aren't just individual battles. They are these huge, pervasive societal challenges with really deep roots and far-reaching consequences. From understanding those classic symptoms to grappling with the global burden, from self-care to big national programs, the interconnectedness of diet, activity, genetics, even socioeconomic factors, it's undeniable.
Yeah, and if obesity really is replacing undernutrition as a primary public health concern in so many places, what does that tell us about how health challenges are evolving? And maybe more importantly, what kind of truly innovative community-level solutions do we need to actually shift this massive iceberg for the generations to come?
That's a powerful thought to leave with. We hope this deep dive has given you a clearer picture and maybe even sparked some thoughts about how these insights apply to your own life, your family, or your community. Keep learning, keep questioning, and keep being well informed.